Hi, welcome to the AUCD Plenary, Leading Change Plenary, Do You See Me? The Impact of Missing Disability Data on Research and Public Health. I'm Dr. Kara Ayers. I'll be moderating today's panel, and I would like to introduce you to our guests. So first we have Dr. Monica Mitra. Dr. Mitra is the Nancy Lurie Marks Associate Professor of Disability Policy and Director of the Lurie Institute for Disability Policy at Brandeis University. Her research focuses on the health and well-being of people with disabilities and their families. She co-leads the Community Living Policy Center, the National Research Center for Parents with Disabilities, and the recently launched National Center for Disability and Pregnancy Research. Dr. Mitra is co-editor-in-chief of the Disability and Health Journal and the 2021 recipient of the Peggy Nosek Award from the American Public Health Association Disability Section. Brian Russell is the Emergency Management Coordinator with Disability Rights Florida, where he works to ensure the needs of persons with disabilities and their caregivers that they're included in emergency planning and response efforts across the state. Prior to this role, Brian was the program manager for the Florida Department of Health's Disability and Health Program, where he focused on adapting and implementing public health interventions for persons with disabilities. During emergencies and disasters, Brian serves as the State Access Coordinator with the Florida State Emergency Response Team, providing guidance and recommendations to ensure the needs of persons' access and functional needs are met during all phases of disasters. Prior to joining the team in 2016, Brian managed the Disability Employment Initiative with Career Source Gulf Coast in Panama City and other public health programs at the Bay County Health Department. Nasra Nicola is the Health and Disability Program Coordinator for the Office of Health Equity in Massachusetts Department of Public Health, MDPH. In this capacity, she works to promote the health and well-being of people with disabilities in the Commonwealth and eliminate health inequities by transforming public health systems and sharing power with the disability community. Her efforts include providing training and technical assistance to public health programs to build their capacity to partner with individuals with disabilities in their work, whether it be data collection, communications, policy development, or direct services. She works extensively with cross-department initiatives such as the Data Collection Standards Steering Committee, including the SOGI and Disability Data Standards Development Teams, the Massachusetts Pregnancy Risk Assessment Monitoring System, or PRAMS Advisory Committee, PRAMS, and the Racial Equity Team of the Office of Population Health and the MDPH Disability Working Group. Thank you, Nasra, for getting us started with some acronyms today. And just a little bit about myself. I'm Kara Ayers. I'm the Associate Director at our University of Cincinnati, UCED. I'm also an Associate Professor at Cincinnati Children's Hospital. I'm the Director of the Center for Dignity and Healthcare for People with Disabilities, and also the co-founder of the Disabled Parenting Project. My interests are varied, but they include disability identity and culture, parenting with a disability, healthcare equity, bioethics, community inclusion, and the use of media to teach, empower, and reduce stigma. So I do my best to infuse the mantra, nothing about us without us, into my work. So I'm really excited to bring all these perspectives and experiences over, I'm thinking of experiences over the last 18 months with the critical public health response that we've seen, but we know that it goes far back beyond that. So thank you all for joining us for this plenary, and we're going to dive in talking about exploring disability data, the gaps in data collection that we see, and really the impact that that missing disability data has on current research and public health efforts. So you're going to hear today during the session about examples from state health departments, academic university centers, as well as community partners. And we really welcome you to submit your questions and comments and responses to us. We'll be taking those near the top of the hour at about the 12:50 mark Eastern time. So we want to hear from you. We want this session to be engaging and interactive. So we have some questions that are going to lead our discussion. But first, I wanted to give our panelists an opportunity to frame up and provide some context of missing disability data on research and public health from each of your unique perspectives. So Monica, would you get us started, please?
Of course, and thank you, Kara, for the introduction, and thank you to AUCD for inviting me to be in this panel. As Kara mentioned, I'm Monica Mitra. I am a brown woman with black hair, with a black and white check blazer and a blurry background. So I have been investigating, thinking, trying to find a solution for disability data and really the lack of disability data since the 90s. So in the 90s, I finished my dissertation, my PhD dissertation, and was focused on employment and occupational choice of people with disabilities. And I analyzed the survey at that time, which was still there, is the Survey of Income and Program Participation. And after I graduated, I was at the Department of Public Health, working, too bad I wasn't working with you, Nasra, but at the Department of Public Health, the Health and Disability team. And that's where I really became aware of both the lack of a standardized way to identify people with disabilities, the inaccessible methodologies that are used in large surveys or even small surveys. And the third was really the need for disability data. And again, we were light years behind where we are right now, because for example, even the behavioral risk factor surveillance system or any survey had a different disability questions, just a different set of disability questions. So a bunch of people just got into the room together, kind of decided these are the questions. There were some guidelines at that time, but really there was nothing consistent. So if you analyzed, for example, BRFSS data from one state and you analyzed, from Massachusetts and Oregon or Massachusetts and California, you'd be getting different population groups. So I think that's sort of been ingrained in me. And with, we had a very strong, and we continue to do so in Massachusetts, a partnership and advisory group. And so with this advisory group, as well as with my colleagues at that time, Paul Tupper, Dennis Heapy, we really got into the room and tried to, instill a culture where disability was considered to be a demographic variable. That disability was a health disparity population. And that quest, unfortunately, still continues. And I just want to mention one other piece of it, right? So, which is, when I left the Department of Public Health, I went into UMass Medical, and one of my first projects was, the first grant I wrote was on pregnancy and perinatal health of women with physical disabilities. And I wrote this grant primarily because I was writing a paper using PRAMS data. And I realized, which is the pregnancy risk assessment monitoring system that, NASRA is involved in. And as I was doing the literature review, I realized there was really very little information and data on pregnancy health, perinatal health of women with disabilities. And why was that? And this is in the United States. Why was that? Because none of the surveys at that time, including the PRAMS, included disability questions. So as a result, this population was entirely missing in the research, in the data, and then of course in policy and programs. So I think that just is sort of different examples of in terms of in my research and my background, where I both felt the absence of data and also the importance of having a standardized way to identify disability. I'm going to stop right here, and I'm sure I'll continue.
Thanks,
as yes.
Yeah. Brian, what about you?
Hey, thank you. Thank you so much to University of Cincinnati, as you said, go Bearcats, for including me and inviting me on this panel. It really is an honor to be on this with much more distinguished people than me. So I do appreciate it. So one thing I noticed, so while working for the Department of Health at our central office, I discovered that there was a lack of inclusion or a lack of disability prevalence data in our state and local reports. The data was there. I mean, we used the BRFIS data. So the data was there, but to identify it, to find it, it would take almost an act of Congress. It was really hard because my background is not statistics. It's not numbers at all. So math scares me. So I would have to depend on our EPI team and our evaluation team and they were great, but at the same time, it was really hard to dig down and find the numbers, especially when we're trying to show the need for disability inclusion in public health issues, whether it's heart disease or people with diabetes. People who have disabilities are about 3 or 4 times more likely to have diabetes. Same with like heart disease, stroke, asthma, and any other wide variety of the social determinants of health. So from a planning standpoint, it was really hard to be able to communicate that need to the county health, to our county health departments and our leadership in the state as well. And by doing that, you know, I also noticed that many county health departments weren't including disability as a demographic, and they sure weren't including disability rates in their community health assessments. So from a public health standpoint, not including disability prevalence in your community health assessments, in your planning documents, that's going to mean that people with disabilities are not included and are not included in county health plans. They're going to be left out. They're going to be ignored and left out. So it's, I mean, and we know this, but it is vital to the health of our communities. It's especially vital to the health and lives of people with disabilities and their families and their caregivers that public health agencies, both at the state and especially the county level, include disability as a key demographic indicator. You know, this would be in any of their reports, any of their surveys or their assessments, and especially planning documents. You know, by excluding them, and to exclude them is definitely to neglect people with disabilities, is to neglect their health, and you're actually denying them access to healthcare services. You know, that's kind of the way we see it. You know, we've been working hard with our county health departments to encourage that. You know, we're not there yet. We have made some strides, but we're definitely not there yet.
Great. Thanks, Brian. I really I appreciate the way you emphasize the word exclude too, because often, you know, we talk about missing or overlooked or forgotten, but the ramifications are exclusion. And I also like that you mentioned that, you know, data and numbers and math aren't really your thing. I'm sure that, yeah, I'm sure that we have a number of people in the audience that data, you know, as yesterday's opening session handled so beautifully, I thought that research can be intimidating, as can data discussions, but its impacts, you know, are felt widely. And so all of us, whether we're data people or not, are impacted by it. And Monica, I think you made a really nice point too about the connection to data sets, to kind of flowing down to policy and impacts as well. So I'm excited about learning more about your perspectives. Nasser, what about your thoughts on framing this?
I mean, Monica and Brian covered everything so well. I'm not sure what there is left for me to say. But just for intros, I'm a fat, light-skinned femme with dark hair and sparkly cat's eye glasses. So I like to think, so I came from an independent living background before I went into public health. And so I always think of myself as a disability rights person in public health rather than a public health person who got into disability rights. And so when I came to DPH, I was like, okay, we always hear that, you know, public programs are data driven and, you know, we can't do anything without data. And I'm coming to DPH and that is the land where all the data is. Not actually, as I think Monica and Brian both detailed. So we have in the public health system kind of 3 traditional approaches to disability. First is prevention. So disability is an outcome to be avoided. And fear of disability might even be used to encourage desired health behaviors. So, you know, watch out, if you drink and drive, you'll end up, you know, with a spinal cord injury or whatever. And if people report disability at all, it's usually in the, like, our intervention failed to prevent this outcome list. The second model is irrelevance. So disability is a demographic category, sure, but it's minor and it's too difficult to collect, and we don't put it in self-report surveys because people won't answer that many questions, and we don't collect it in, automatic administrative data sets because, well, our database doesn't have a field for that. And so again, like, we know it's there, but we make choices not to collect it. And then inconsistency, which is, I think, where the best intentioned programs kind of are at this point. So we recognize that disability demographic data is worth collecting, at least in some specific programs, but the definitions are inconsistent and the data sets aren't linked, so you can't draw conclusions because you never know if, like, the type of people with disabilities you're looking at from 2019 are the same types of people with disabilities you saw in 2017. And so you can't really say anything about how this group of people experienced those two intervening years because they may not be the same group of people. And so it leads to kind of what we call, at least internally in my small group of nerds in DPH, the cycle of invisibility. So you can start anywhere, but disability demographic data is missing or inconsistent in data sources, which leads to data-driven policies and research excluding people with disabilities because no data is available. And then that leads to data systems not collecting disability demographic data because it's not relevant to policy or research. And so this just keeps going around and around and around and widening this barrier every time that cycle repeats itself. And we end up with nothing. We end up with programs that can't tell us who we are in the community, what we need, or what would be helpful. And just as an example, people have been talking about the BRFSS, which is the Behavioral Risk Factor Surveillance System, which is a major source of population level public health data for a lot of programs. And according to that, the percentage of people with disabilities in Massachusetts is usually around the 20 to 30% mark, depending on the year. And that is a survey that is done by telephone of the civilian non-institutionalized population. So who that excludes are people who are in institutions, long-term care facilities, group homes, residential schools, people who are incarcerated, and people who are unreachable by telephone, which is to say a lot of our community. Like, if we know our folks, we know that this is where a lot of our people are. And it also doesn't include explicitly people with mental health disabilities. Mental health is still considered an outcome, not a demographic. So when you include all of those populations, our preliminary results, and super, super preliminary, like, don't take this to the bank or anything, but we're seeing closer to 61% of people in Massachusetts having disabilities. And a lot of those folks come from people who were deliberately excluded in the existing survey methodology. So I will leave that there with just a thought of, like, those 40% of the population who have disabilities who nobody even knew existed, even with the best of data that we have currently available, we're still catching, like, maybe a third of the disability population. And that's not acceptable, and we need to make better choices.
Yeah. Wow, that really shifts the idea of irrelevant. I mean, that turns it on its head when you're talking about well over half of the population, and also just a huge chunk that has been completely excluded previously. So thank you, Nasir. That was a great opening. Let's build on that, more on the piece you mentioned about inconsistency in definitions. And Monica, you mentioned this as well. So we know that various government entities, public health data sets have these inconsistent disability definitions. We've talked a little bit about how they hinder or facilitate data collection. But I wondered if, Monica, you can get us started. What is your preferred approach to defining disability in data?
That's a loaded question, Kara.
Right.
So we know that definitions vary, right? Definitions, I mean, again, it depends on the context. If you're looking at the eligibility criteria for programs, if you're thinking of a civil rights definition, and then if you're thinking of a survey definition. But in terms of just kind of narrowing in the public health, even that depends on whether it's part of WIC and whether you're looking, or whether it's part of SNAP or whether it's a survey definition, right? And again, then within surveys, are you looking at children and parent-reported surveys? Are you looking at youth and young adults? Or you're looking at, is it an adult population? So again, even within the survey, you're going to find different definitions depending on the population. In terms of a preferred definition, that I'm going to just say the definition that I generally use because of the work that I do is, especially when I'm looking at survey data, is generally the ACS 6 questions. As Nasra had pointed out, that there are real challenges with that because it doesn't really include people with mental health disabilities. And even though it does include a question on cognitive disability, we're really not quite sure what that population is, or what population that question is capturing. It's sort of this kitchen sink of question, of a question. So I think that's, there are significant issues with this. Having said that, it is what we have, and and I'm hoping that this panel will help is elevate the need for a more consistent, validated set of questions that really captures, as Nasra pointed, all the people who are actually not included, and again, survey methodology is a whole other piece of it, and I'm not going to answer that right now, but just in terms of people with psychiatric disabilities as well as people with intellectual and developmental disabilities. So what we really need is a more comprehensive set of questions. And I just want to also put a plug in that it doesn't include and it doesn't capture really consistently or with any rigor is people who need home and community-based services. Mm-hmm. Or long-term supports and services. But I'm going to hand this over to Brian or Nasra. I don't know if either of you want to add something.
One thing I do, one area, Nasra, and this is kind of tagging onto your, onto what you said earlier as well, is a lot of the surveys, like you mentioned, a lot of the surveys that, that they don't follow the same group of people. I have had this conversation with with my now former disability and health program evaluator. We've had this conversation a few times of how the BRFSS and other surveys really need to update their question, the way they ask questions. Whether it doesn't need to just be a telephone call. They need to update their platform. They need to update how they do this, how they reach out. So absolutely, but I do think that's where on the local level, communities can really look at and invest in their community, invest in how they do their health assessments. It's a lot easier for a small community to, for lack of a better word, track, I hate using that word, but to assess the same group of people over time, as opposed to a state or a statewide or a nationwide survey. But one group of people that I think have been excluded are people who are in institutions for mental health reasons, for disability reasons. They're not surveyed. They're not included in the BRFSS. They're not included in the census. So we really don't have a good feel for the state of disability in our nation and in our state or our communities. And I think that needs to be addressed at some level. I think it has to be addressed.
Yeah. And coming off of that, Brian, we always say, in public health, if you can't measure it, it doesn't exist. And what does that say about people with disabilities in institutions? Like,
right, absolutely.
Literally invisible.
Mhm.
And I mean, I think that allows the system of institutionalization to keep going because nobody has any idea who's there, whether it's good for them. Like, we can't compare outcomes even from people with disabilities in institutions versus in the public because we can't get a handle on who these people are.
Exactly.
We keep talking about the ACS 6 questions, and so for fellow people who are relatively new to this, I just wanted to read out what the questions are. So there's 6 yes or no questions. The first one is, are you deaf or do you have serious difficulty hearing? Yes or no. Are you blind or do you have serious difficulty seeing even when wearing glasses? Because of a physical, mental, or emotional condition, do you have serious difficulty concentrating, remembering, or making decisions? And frankly, because of one of my disabilities, I have trouble remembering the beginning of that question by the time it gets to the end. So talk about methodology. Do you have serious difficulty walking or climbing stairs? Do you have difficulty dressing or bathing? And because of a physical, mental, or emotional condition, do you have difficulty doing errands alone, such as visiting a doctor's office or shopping? So those are the 6 questions that most of our disability research that's based on survey data come from. And so I'm just sort of curious about how people in the audience, like if you listen to those questions, which of those do you see yourself in? If you see yourself as a person with a disability, do those capture your experience? Do they make sense to you? Do they describe you in a way that feels relevant to your experience of health and wellness and your body and mind? And like, as Monica said, they're what we have. They're like the best we've come up with, more or less. There are a couple of, I would say, equally popular options that are used maybe less frequently in government settings, more frequently in academic settings. But that's the best we've got. And so people with disabilities have to really try and fit ourselves into that conception rather than make the disability definitions fit us and our experiences. So one of the reasons that my team arrived at such a big number for people with disabilities is we went intentionally broad. Like, we didn't go completely ridiculous, but we looked for anything that is an aspect of someone's body or mind that is different from mainstream or normal, different from what the public health system expects, and that affects your experience of or interaction with the world. And that is really broad. But that is, I think, how we in the disability community kind of see who we are in the world. It's this interaction between our bodies and minds and the outside system. And so as much as you can get that from electronic medical record data, which is where those numbers are coming from, which is the most dehumanized, impersonal data set you can possibly have, I think that is a better sense of who we are and will give us a better sense of what we as a community need from the system, rather than like which of these predefined buckets do we fall into based on symptoms. And symptoms there is in big air quotes.
Yeah, big quotes. Yeah, I think I'm also fascinated by the way people interpret those 6 questions that many of us kind of reluctantly describe as our preferred because it's what we have. I know myself, I am a wheelchair user, and I've talked to other friends with similar disabilities that we find the question about, do you have difficulty walking? So it's obviously, a functional definition normed on non-disabled, ideas of mobility. But I've heard more than one person say, no, I don't have difficulty walking or climbing stairs. Like, I don't do that. I don't try that, Like, and it's not being like contrarian or difficult, but it is like the way that we can interpret these questions can be meaningful. I mean, the question, the question doesn't ask, are you able to move about your environment? Do you encounter we could all think of different questions, but also one's personal identity with disability is more or less tied into these answers. And I know Monica and I share this challenge in working around the issue of parents with disabilities, that there's still so much stigma and discrimination that faces parents with disabilities, especially parents who may have an invisible disability, say an intellectual disability, that when asked, are you a parent with a disability? We often have very few people raising their hands and saying yes. But, we have this gap between service provision. We want to reach people that need it, and policy. We need so much work to refine our policies to be less, I say less discriminatory because that's my goal at this point, but because they're just so blatantly. But I wondered, so this next question centers around what can we do in the public health sector to support a greater understanding of disability identity to inform existing definitions. And so just kind of reflecting on the flip side of this, we've been looking at what questions are asked of people with disabilities, but what, if anything, can we do around this idea of disability identity within people with disabilities?
Hire more of us.
Yeah, why don't you get us started, Nasser? Hire more of us is a good start.
Yeah, so yeah, my off the cuff response, right, is hire more of us. There is absolutely a place for academic expertise. There's also a place for lived experience, and I think there's a huge potential for both of those things to be found in the same person. So it's not just a matter of like, pick a random disabled person out of the phone book and give them an epidemiology job. It's people in our community are actually knowledgeable about this stuff. Hire those people. Because I think we do have both a perspective on how data needs to be collected. Like, we know the trials and tribulations of coding things in SAS or whatever, and getting consistent data sets. But we also know if you walk up to a person in the community and say XYZ, you're not going to get the answer you think you're getting, and the data you collect aren't going to mean what you think they say. So yeah, and in the absence of, or in addition to hiring us, I think advisory groups like the one we have in Massachusetts, I think we could even be doing better. But actual people with disabilities who will vet your programs before they're launched, not afterwards, and tell you, when you're messing stuff up. We had a really interesting experience in Massachusetts with our COVID community impact survey, which I will maybe hold for later, but the deaf community absolutely came for us with that survey, and they were absolutely right.
Yeah.
So yeah, you listen, you admit when you mess up, and you try and have people around you who know better and who you listen to.
Summary. Yeah, Monica?
Yeah, absolutely hire, mentor, but also the public health schools, for example. How many of the schools include a program or even classes? I'm going to start with a class, okay, on disability and health. So it is about that next generation of practitioners, that how we're mentoring them, what are they learning about disability, and who's part of that? Is it okay to have a disability identity in a school? As in, are people comfortable to have it given the stigma? So I think that's one part of it. And I think it just comes with a larger, a culture shift, a paradigm shift, right? And I think Nasra had mentioned this earlier, is about this medical model, right? That still exists in public health. And so while we're talking about Massachusetts, I think Massachusetts is very unique in many ways, right? So what we have to think is a culture shift where disability is no longer a preventable outcome, but moving it, wearing my nerd hat from the right side of the equation to the left side, and having it as a health disparity population. So, that needs to be done. And also collecting data is also not enough, right? It's what you do with the data and how you use it to impact policy and practice. I think Brian had some great examples there where it's not used. And I think, so you collect it and then it's in to age myself in some file cabinet sitting there, but instead actually used as a demographic in all the dissemination efforts to the communities, to all communities, but particularly the communities where you're collecting the data from. So I think that there has to be an awareness and a culture change. So and that's just step one. But that has to happen at the local level, the state level, and the federal level.
Yeah.
And I think just to piggyback off that on dissemination, Monica, it has to be written in language that the people who are being written about can actually understand. And sometimes that's not even written. I'm actually working on, God help me, a series of short videos about public health topics in plain language to launch a YouTube channel for my department, because we publish these data briefs, and so Monica and her team actually help us translate our written data briefs into written plain language data briefs. But I can see professionals reading that.
Mm-hmm.
But is, J random person with an intellectual disability going onto the Massachusetts DPH or the Lurie Institute website for fun on a Friday reading data briefs? Probably not. And so we talk about in other communities, meeting people where they're at and communicating accessibly and approachably. And we don't do the same thing for people with disabilities. Arguably, we don't always do it well for any other population either. There's plenty of room for improvement. But just the idea of, and I love my epis, I do. Epidemiologists are fantastic and necessary people. Getting an epidemiologist to present in front of a room full of people with disabilities and not only say things in an accessible manner, but not just point to tables of data on their slide that the blind people in the room can't read, is a huge learning curve. And I find a lot of my time in my department is not only operating my own program, but building capacity in every single other program, so that if, God forbid, I get hit by a bus or lose grant funding, each of which would be equally catastrophic, other people still know what to do. Because it can't just be the one or two loud disabled people in the room constantly saying, well, did you run this by anybody first? It needs to become a reflex.
I just want to add to that, Nasra, your point about public health communication. That really needs to be reframed, and for all communities, but particularly for disabled communities. Mm-hmm. And the other piece of it, and I think, again, building on what Nasra said about capacity building. The CDC, for example, funds, including Massachusetts and maybe 9 or 10 other states, on a capacity building grant. And really a capacity building grant as in for, building capacity within these departments of public health on supporting people with disabilities and improving the lives of people with disabilities in those states. Why is it only in 10 states or 12?
It's a real good question. It's 10.
Why is it not in every state? And why it should be part of the health equity efforts in every single state and not just a select number. So I think we really need forces from local to federal to really change and to have a culture change.
And I'm actually proud to say that when we applied for our CDC COVID health equity grant funding, department-wide, equity in general, people with disabilities were included as a priority population in that grant application in a non-disability specific grant. Which is not something you see often. Our PRAMS program does it because our PRAMS people are awesome. But other than that, that's not a demographic that people have really considered except in the niche disability program space. So I really hope I don't know what other states are doing around their COVID equity efforts. I hope they're doing stuff like that, but it was really, like I actually got a little choked up when I saw that grant application, and I don't usually cry at grant applications. So
Not at least at that phase, right?
Yeah,
At
right.
seeing the
I was
description.
going to say I've cried at many a grant
Yeah,
application,
yeah,
but not in the same way.
not tears of joy.
No, not at all.
Well, yeah, and so yeah, and I kind of want to step in for just a second, and I want to agree with both Nasira and Monica. A couple of the things that we've noticed here in Florida is the inclusion of people with disabilities in schools of public health, schools of medicine, schools of dentistry. Yeah, it's very few and far between. There's really nothing currently in policy or practice to do, to encourage disability competency. When I was managing the disability and health program, University of Florida was a major partner in that. And one of the things we did was we created a disability competency training program for public health students. The only problem with it was only at UF, and we've got other schools of public health and schools of medicine in the state. And even still, my UF team would go in and teach a class one day. It would be Public Health 201. Today we have a special guest speaker, that kind of thing. So yeah, there needs to be across the board policy change, definitely a definite sea change in requiring public disability competency being taught as a required course, multiple courses actually. Another thing I would love to see is physicians with disabilities. I have friends who have disabilities, and one of the big things is one of my friends is a wheelchair user, and her physician understands that and actually understands everything going on with that. But she said, she would give anything to be able to walk into a doctor's office or into a hospital, heaven forbid an ER, and see a physician using a wheelchair, that kind of thing. So we definitely need to do, nationwide, encourage more people with disabilities to go into the medical field, and make it easier for them to go into the medical field. Make med school easy, not easier, but make med school more affordable, make getting a master's in public health more accessible, I guess would be the right way to say that. Definitely that. One quick thing is, before I left Department of Health to come to Disability Rights Florida, we were strongly encouraging, can't require them, but we can strongly encourage, gently nudge our county health departments staff to go through and complete disability competency training.
Can I
They don't like the
start?
word policy.
Yeah. Can I start trouble, Brian?
Please. Please do. I usually do on a regular basis. That's why I'm now in Disability Rights Florida.
So you were talking about making medical school easier, and then you corrected yourself and said not easier. I think, frankly, easier is not necessarily a bad thing in this. If you have a medical training system that's like an elaborate hazing ritual that teaches you to ignore every single physical cue your body is sending you about exhaustion and like wellness and pain in order to get through medical school, and you build up a culture where people are proud of that, you're never going to have a system that trains people who actually, that allows people with disabilities to get through, first of all, but also trains the people without disabilities in that system to understand what it is to actually have pain that you're not going to ignore. The mindset that you have to encourage in yourself in order to survive med school is just profoundly hostile towards working with people with disabilities in any kind of competent and humane manner. And the fact that anybody comes out of this knowing how to work with us is frankly a miracle.
Yeah, and I haven't seen similar research on public health graduates, but I have seen really alarming research on that when we look at bias about disability at the start of med school compared to the end, unfortunately, bias has gotten worse. There's more bias. So we're not undoing ableism in, at least the research I have reviewed has been in med school training. And I worry that, I don't think that we're undoing ableism in public health training either, whether it be just by blatantly ignoring it or by actively kind of, as you brought up, Nasser, like perpetuating it, and really teaching people to ignore signals and kind of have this idea that you can overcome, right?
Yeah. And I mean, we don't have like 36-hour on-call shifts necessarily in public health, but like the past 2 years we kind of have.
Yeah.
And the kind of all hands on deck mentality that comes in a crisis. Like, I've lost a lot of colleagues to just burnout in the past couple of years, particularly disabled colleagues, because like everybody is going to burn out and like not have enough energy to deal with life after a certain number of 80-hour weeks. People with disabilities are the canary in the coal mine for that.
Yeah, great point. So I just want to send a quick reminder to our audience to send your questions through so that we can answer those when we get to that portion of our talk. I wanted us to tackle a couple more questions. First one on your thoughts around proxy responses. So proxy responses are when a parent, a caregiver, or guardian responds on the behalf of a person with a disability. And we see these in some data sets. There are definitely reasons cited why people use them. So I wondered, maybe Brian, if we could start with you and how you've seen this play out. When should proxies be used and when should they not?
All right, couldn't find the mute button. It's a great question. That's a really great question. I guess from a healthcare standpoint, when the person is incapacitated, maybe, that really kind of harks back though to training and competency training and the field where people can understand, do they need a proxy? Oh, well, they have Down syndrome, so they must need a proxy if they have Down syndrome. Well, no, they don't, it's a really great question. Personally, taking all my hats off, people should, just as you have a disability doesn't mean you can't think for yourself. We've seen proxies being abused for a really long time, for a very long time. I personally would be fine with ending the practice altogether. I'm sure there's a need for it at some point, but I think I would personally lean towards, using it sparingly, if at all. And definitely
good points.
And definitely crank up the disability competency training for everyone in that, for lack of a better word, industry or in that field.
Mm-hmm. Yeah, you bring up a good point about, is it truly an accurate capacity assessment to determine that, or is it an inability to communicate effectively with that person, or
absolutely,
gather data how you should?
A lot of times, and we see this in emergency management, in a lot. Well, not a lot, but we do see it in emergency management. Well, do I really have to? Do I really have to let them come in this general population shelter? I mean, they have autism, and I don't really feel like having to, create a special sensory room for them. Or here in Florida, I work for a certain Florida governmental executive. Do I really have to have a certified sign language interpreter with me? at my press conferences. I don't really want to have to hire one, you know? So yeah, so I think there's a definite culture of laziness as it relates to that. But yeah, definitely I think we do need to do a much better job with this.
Points, Monica or Nasra?
So this is obviously a pretty controversial issue, and if proxy respondents if they are even appropriate, has to be with consent. It has to consent. It has to be built into that process. And when that data is communicated, it should be clearly communicated who the respondent was. Because often you don't understand that until you dig deeper, and it's not even sometimes in the fine print. So that clearly, and if it's a survey that includes both self-report and maybe 5% or whatever X% are proxy respondents, that should be very clearly communicated, and the data should be stratified accordingly.
I agree. And I think a lot of this can also be helped by, again, by training of people who administer surveys. So I think there's a lot of reluctance to allow people to rephrase questions, because then it isn't technically the same question, and you might be compromising the validity of the results because people aren't all answering the same questions. And I get it. I do. But I also think that if you're asking questions that are too complicated for the people you're talking to answer, you should ask better questions rather than ask someone else. And so if at all possible, I think everyone benefits from having simpler, more plain language questions. And if you can universally design that stuff a little bit, I think everybody's going to have a better experience. I really don't think, the folks that we hire to administer the census love having conversations on scripts that they probably can't say without stumbling. Lord knows I can't. So yeah, maybe just chill the questions out a little bit and you'll get better responses from more respondents. If there is literally no other option, sure, proxy respondents and acknowledge. But I would also not only like to see a disclosure that a set of data was collected from proxy respondents, I would also like to see an explanation in that case of why.
That makes sense. Yeah. So we have some great questions coming in from our audience. Let's take one more of our kind of predetermined questions that I wanted us to be able to highlight some gaps in disability data collection that we see. So how do we see gaps in disability data collection impacting the public health response? And you can choose to make this specific to COVID-19 if you'd like. I know several of us have been in the trenches with that, or if you were like me, sometimes done with talking about COVID-19, you can also expand it. But just to kind of, before we move to audience questions, and maybe Monica, you can start us off with this. How do you see those gaps in impacting public health response?
Sure. So I want to go back to the what I brought up earlier in terms of paradigm shift. So and what does that mean? It means that we have to include, well, we need a set of better questions, but I'm going to just go beyond that, is standardized questions and surveys at the state, local, at really at all levels. We also need to ensure that the questions include people with intellectual disabilities and the populations that are missing, as well as identify people who have long-term service and support needs. We need to ensure that the methodology for collecting the data is accessible. and I think Brian raised an important point with proxy respondents, is also when whoever's collecting the data, if this is an individual, to ensure that they understand disability and understand disability rights, and so the way the questions are asked are not ableist. And then finally, I think it's the use of the data, right? So how is the data used? Is it used? It needs to be used to break, as Nasra pointed, the cycle of invisibility. So collecting it is just not enough. So public health departments across the country have to be able to use the data and going back to Kara, we have seen the disproportionate impact of them. While we know it, a lot of our evidence is also anecdotal or it's spotty, right? So how do we, this has really clearly taught us the importance of the need for disability data collection. The National Immunization Survey is an example, and Nasra, maybe you can describe the issue related to that. And of course, I think this is something that we need to have a public health force that is inclusive of disability. And we need to, as a community, as including schools, including medical schools, is really to train, mentor the next generation of disability practitioners.
Hey, this is Brian. Yeah, so talking real quickly, definitely agreeing with Monica. One of the issues we saw in disability collection, data collection, as it relates to COVID, was, at both the federal and the state level, it took a while for the CDC to to get moving on it, but they did finally start, addressing disability and COVID through the household pulse survey, where we can now look and see, how in Florida, so many people with disabilities have either gotten the vaccine or will not get the vaccine, how many have gotten COVID, that kind of thing, which is good. But, we've discussed this earlier as well. At least here in Florida, as much as I liked our EPI people, and I love our EPI people with the state, they didn't want to touch this. They didn't want to touch COVID and disability inclusion. I mean, it was hands off. We don't have time or the staff to add one more question to this. Just one overall disability question to our COVID testing, to our COVID, to any of the COVID numbers. So, I mean, it was, so during the initial response, I was having to try to figure out, I was trying to have, work with other partners to get their specific disability related data. It was a lot harder than it should have been. And it was because of laziness, and they just didn't see it as an issue, which really impacted planning. It really impacted, our overall planning on how do we reach people with disabilities in this. Sadly, one disability group home in Tallahassee had an outbreak of COVID, and several people passed away because of that. It was really hard having to remind people, our leaders in the state and local level that, people with Down syndrome, people with certain types of disabilities are much more susceptible. When it was coming out, when resources were scarce, we noticed it was, at the state level, there really wasn't an emphasis on disability data. And that's needed, especially during a pandemic or during any other type of disaster. So we really need, and so that kind of ties in with, there has to be a push from the federal side, from the CDC, from the National Institutes of Health, from FEMA. There has to be a push to require, to strongly encourage state and local leaders to include disability data as a key demographic indicator, to specifically include people with disabilities on your community health improvement teams, to include people with disabilities in your community health plans and community health improvement plans. Because we all know if they don't see them, they're not going to plan for them. And if it's not documented, if you can't collect the data, then it doesn't exist. So we have to have data. We have to have that. And if it takes a federal policies and laws, then so be it.
It's that invisibility. Yeah, Nasser, anything else gaps wise you want to point out?
Yeah, so I actually wanted to do kind of a compare contrast from two different points in the pandemic in Massachusetts, because I think we did some things not great, and I think there are some success stories that we actually have been able to have. So when the vaccine was first being released, everyone at this point probably knows like the CDC list of prioritized conditions, and it was this like kind of weirdly specific list of some things that could affect your health and make you more susceptible, but they had like immune suppression due to organ transplant, but not immune suppression due to taking immunosuppressants because you have an autoimmune condition. Like these very specific things. And it turned out that that was the best data-driven policy that we could have, because there were these populations that had had previous research done on them, right? We knew what respiratory illnesses looked like in people with asthma. We knew what, coronaviruses looked like in people with organ transplants. We didn't know what any of these things looked like with people in rare connective tissue disorders, because there just aren't that many of us to study. And so even though we and our doctors and everybody knew this was going to be a big deal and we need to get vaccinated as soon as possible, the best data-driven policy we had could not accommodate that. And because I think everyone was rightfully in panic mode, we didn't feel the flexibility or the authority to exceed that policy, to use our common sense knowledge and kind of patch the gaps there ourselves, because we didn't have data to support us, to stand behind us. And there was fear about doing anything that the data didn't clearly indicate. So that said, our COVID Community Impact Survey team, the CCIS folks, who are just a group of scrappy social justice motivated epidemiologists in our Department of Public Health, wanted to see what the effect of the COVID quarantine measures and all of the preventive measures that happened before the vaccine were, and to see also how people were getting information, how they were getting access to testing, and really use that to build a model to increase access to vaccination and to whatever's next. And I didn't have to ask them to include a disability question, which again, choked up right there. And so they used the standard 6 questions that we were talking about earlier. And it turns out when you ask questions, you get answers. So we found out things like our messaging about sneezing into your elbow was a barrier to blind and visually impaired people who needed to take people's elbow to be guided by a sighted guide. Like stuff that nobody would have considered if they hadn't asked. We got just the richest data on not only who in the state is likely to have job loss or reduction of hours, but certain categories of people with disability were more likely to experience job loss versus reduction of hours, et cetera. So we could really target our response to that. And that was actually what drove the inclusion of people with disabilities as a priority population, because we could see that people experiencing barriers to testing, barriers that we had put up to information access, that all of those things were really targeting the disability community in a way that we could now prove and justify. I will say, although the survey was translated into, I want to say 12 different languages, they were all written languages. And we rightly got flack from ASL using deaf people who were like, some of us can read this, some of us absolutely can't. And so you're getting different perspectives from different people. So we ended up having a focus group, or a series of focus groups, honestly, in ASL. And we could go deeper on a lot of the questions and really get at, okay, well, what are ASL users experiencing versus people who primarily communicate in, written or spoken English. And not only was that an impetus to figure out how to include videotaped survey options next time so that people can actually answer the same survey questions, but in their native language, being able to get qualitative data to get people's own experiences in their own words was so powerful. And I think what was the original question? How can we fill the gaps? I think some of what we can do is stop privileging quantitative information exclusively. Because numbers can give you a sense of how big a problem is. They can't give you a sense of what that problem feels like. And some of what you need to know to address that problem is how it's being experienced by the people who are neck deep in it. And I think that's something, honestly, that people who are not math people recognize intuitively. These numbers don't actually mean anything to everybody. It's the way we frame them. And we were able to talk about, for example, how some of these results we were seeing in the COVID impact survey weren't the result of disability, they were the result of ableism. And we were actually able to say the word ableism and explain structural ableism in an official DPH publication. We got a little bit of pushback from that from higher levels of leadership, but it was useful. And so really looking to make those connections between the root causes of disparities and what we're seeing on the surface is so important. And I think qualitative data is the link between those two.
Great points. I really
stepping off my soapbox now.
Yeah, I like your emphasis on not privileging the quantitative data only or exclusively. Excellent point there. So as we wrap up, I think we had some great questions submitted. Andrew submitted one that I think would be great to wrap up. And/or you can kind of choose your own adventure if you want to leave us with additional takeaways. I know Brian has some valuable points around local impact. Feel free to weave those in. But Andrew asks us, disability is an incredibly diverse experience and identity. How do we capture the variety of disabled experiences within a defined, quote, demographic or definition of disability? And Nasser, you kind of got us started with that qualitative piece. Do you want to continue on that and/or give your takeaway for today?
So I think including that qualitative piece is important. I think framing your data is important, and really being explicit about what your data do and don't say. I also think that there's always going to be an element of the human experience that data can't capture. And it sucks because we want our data to be as grounded and real and informative as possible and as true to people's real lives as possible. But at a certain point, you have to flatten those experiences to get them on a page. And I think what we need to do at that point is just be as honest as possible about the conclusions we can and can't draw from that kind of flattened out data. And be specific, like leave evidence of what we did so that if people have a better approach to that, they can retrace our steps. So describe what we left out, describe what we had to oversimplify, and let people take it from there. Yeah, so that's my response.
That's a great one. Yeah, I mean, in response to this plenary title too, do you see me describing what we've missed, describing what you see? Brian, what about you? And then we'll go to Monica.
Yeah, so Andrew, that is a great question. I think it definitely requires us, I think, to take a broader view of disability and to have the conversation globally or nationally on what is disability. How do we, I think it's probably time we redefine disability and take the medical model of disability, crumple it up, throw it in the fire and burn it forever. Disability is not something that can be cured. But I do think we need to look at this at redefining it completely. Some people don't see they have a disability. From a public health perspective, we see it one way. From a legal perspective, it's viewed another way. From a governmental perspective of benefits, of receiving benefits, it's viewed completely differently. So I think we need to just have a national conversation about redefining disability. Make sure that everyone is at the table, that everyone is represented. Taking this kind of to a local level, and kind of also leading into my final statement about this too, is it continues to be nothing about us without us. Is at the community level, county health departments here in Florida are required to conduct a community health needs assessment, if not annually, every couple of years. And so, encourage, if you're a Floridian, if you're not a Floridian, still do this. Reach out to your local health department. Ask them, ask them about how they include people with disabilities in their community. How do you know that we're here? Ask them for data about disabilities in their community. Ask them where you fit in their plans. Make sure that you have a seat at the table. If you don't, grab a seat and plop down and say, I'm here, let's talk. See me. Reach out to your local Center for Independent Living. At least here in Florida, our Centers for Independent Living are really active. So make sure that you're a part of that. And if you are a local health department, include people with disabilities, reach out to them. When you're creating your community health needs assessment, create your own. If you don't like the 6 disability questions, that's fine, create your own. My personal background is Southern and a little bit of redneck. And when we have to get something done, if nobody else is doing it, or if it doesn't work, we do it ourselves. So we would create our own stuff and, create your own needs assessment then, and make sure you ask the disability questions that work for your community.
Yeah, that can definitely be impactful on a local
absolutely.
level. Yeah, Monica, what about you with this demographic and diversity of disability? And you can close us out today.
Thanks, Kara. Thanks, everyone. So, when we think of disability as a demographic, we're not boxing it. What we want to do is really instill, and I'm going to kind of go back to my paradigm shift soapbox, is we really need for everyone who is involved in public health, whether it's the EPIs, whether the public health practitioners, to really not just simply collect data, but utilize the data to create policy. Because what we've seen with COVID, right, as one example, is that the lack of data has had cascading effects, right, and has impeded our ability to both measure but also advance equity. And so we need to, both identify people with disabilities, understand the disparities, and move forward with eliminating whether it's the environmental barriers, whether it's the attitudes and the stigmas, whether it's a lack of access for, I'm just going to put in social determinants. And we really need to make that effort. So collecting the data, utilizing the data, and disseminating the data to the communities is really critical in terms of our next steps. So I think we and I'm going to end with this, is we owe it to ourselves, and we owe it to the next generation, is to ensure that the next generation of researchers, practitioners, policymakers include people with disabilities and are also disability informed.
Most definitely. Thank you so much. I've learned a lot from this session. I wish we could keep the conversation going, but I know people will throughout the AUCD conference. So I hope you enjoy the rest of the conference, to our attendees, and thank you so much to our panelists. This has been great. So
thank you.
Bye, everyone. Thanks. See ya.
Thanks a lot.